Innovate. Good morning or good afternoon, everyone. Thank you for joining us today for this webinar on innovative prevention strategies to reduce congenital syphilis rates, hosted by HCET with presenters Chaquetta Johnnon, Amanda Reich, and Jessica Del Toro. My name is Megan Muhlenbrook, and I am a training manager at HCET, and I will be moderating today's webinar. Let me briefly introduce you to healthcare education and training for those of you that may not be familiar. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. For more information about us and to stay up to date with all of our upcoming events, please be sure to follow us on our various social media platforms and to visit our website, hcet.org, as well. Couple quick housekeeping items before we get started. You will receive a link following today's webinar containing an evaluation, and we greatly appreciate your feedback. All archived presentations, including this one, are housed on our website, and you can access them on our events page there. If you have any technical difficulties during this presentation for any reason, please go ahead and reach out to us at our email address, wisconsin@hcet.org. If you're looking to receive nursing contact hours for this webinar, you will be expected to attend the entire webinar, to complete the event evaluation, and to submit the NCH form. This form will be sent to you along with the evaluation email after this webinar, and it will need to be submitted to the email address on your screen here. The presenters today do not disclose any actual, potential, or perceived conflicts of interest that need to be mentioned. And throughout the presentation, we do encourage you to send your questions through the chat box. To do this, you can go ahead and hover over the chat icon, opening the window. Please ensure that you send it to all panelists so we can all see it. We will ask you to submit questions throughout the presentation at any point as you have them, but we will save all questions until the end. But please don't feel like you need to wait to the end to send those through. So now I'd like to introduce you for your three presenters for today. So first we have Dr. Chaquetta Johnnon, who is the Deputy Director of Operations with the Louisiana STD HIV Hepatitis Program. She is responsible for assisting with the oversight of statewide STD, HIV, and viral hepatitis program activities and offers program-related clinical consultation. She has more than 18 years of experience with the Louisiana Office of Public Health, including several years providing direct care services as a women's health nurse practitioner and serving as a regional nurse manager. She completed a Bachelor of Science in Nursing and dual master's degrees in Nursing and Public Health at the University of Alabama at Birmingham. Dr. Johnson completed her Doctor of Nursing Practice degree at Vanderbilt University, where she was recognized for her work studying the relationship between contraceptive choice and the incidence of sexually transmitted infections. Next, we have Amanda Reich. Amanda began working on congenital syphilis while at Austin Public Health. She began working for the Texas Department of State Health Services as a public health follow-up consultant, providing guidance to several programs across the state reviewing statewide congenital syphilis case reports and database conversion in 2017. She currently works with DSHS as the Congenital Syphilis Coordinator, providing guidance and technical assistance to partner services programs across the state regarding congenital syphilis reporting. She also facilitates and moderates the fetal infant morbidity review boards on congenital syphilis across 3 counties and writes the Texas Congenital Syphilis Program operating procedures and standards. She currently serves as the co-chair of the National Coalition of STD Directors and CSD Program Committee. And last but certainly not least, we've got Jessica del Toro. Jessica is the congenital syphilis epidemiologist for the Texas Department of State Health Services, where she initiates and conducts analysis on data associated with congenital syphilis screenings, including examining surveillance efforts, epidemiologic trends, and public health follow-up efforts. She first began working on congenital syphilis with the San Antonio Metropolitan Health District as a disease intervention specialist, where she conducted follow-up for pregnant women with syphilis, congenital syphilis investigations, and maternal interviews. In 2018, she was promoted to a management analyst position where she supervised a case management program focused on decreasing congenital syphilis in Bexar County. Jessica currently serves as a core team member on the fetal infant morbidity review boards on congenital syphilis across 3 counties. And without further ado, I would like to hand things over to Dr. Chaquetta Johnnon to go ahead and get us started today.
Hello and good morning, and thank you, Megan, for that introduction. And also thank you to HCET for inviting us to share about our work here in Louisiana on congenital syphilis prevention. And next slide. I'd like to first start off with giving you a snapshot of congenital syphilis here in our state. And as you can see, over the past 10 years, we've had an increasing problem with congenital syphilis cases in our state. Particularly if you make note, in 2016 and 2018, we did have a decrease in the number of cases that we had, but we did see a significant increase in 2019. And what we'll discuss during this presentation are some of the innovative practices we put in place to combat these number of cases and tell you a little bit about how things worked for us. Next slide. And you see also that our case rate is significantly higher than the national average, and that has been true over the past several years, again noting the decreases in 2016 and 2018. Next slide. And when you look at Louisiana as a whole, we have 64 parishes, which other states call counties. And in those parishes, we do have health departments, or what we call parish health units, in 60 of those parishes. We are a centralized health department, and at those health departments, we offer not just STD and family planning services, but other public health services like WIC, immunization, TB, and vital records. But overall, Louisiana is considered a very poor state. The majority of our state is considered a health profession shortage area or does have a low income density population designation. Next slide. And when we talk about our reproductive health services in the health units, in 2014, because of budget cuts and staffing restraints, we did think it was best to combine our family planning and STD services into what is now called a reproductive health clinic model. And through that model, we do offer comprehensive reproductive health services, but as well as our STD services like screening, testing, and treatment for GC, chlamydia, and syphilis. And that's an important piece to really think about as we go through this presentation, because Louisiana does not have a standalone STD clinic within our public health system. We do have one STD specialty clinic, which is located in New Orleans. But then now we've been partnering with another private agency to start a new STD clinic in Baton Rouge. But through our public health system, there is no standalone STD service provided. Next slide. And when we talk about congenital syphilis in Louisiana, in 2018, we did have a reduction or a decrease, in our ranking with regards to congenital syphilis case rates. We had been #1 for many years in the country, And in 2018, we were considered number 3. So we were excited about that. We did have, as you noted from the previous graphs, a decrease in the actual number of cases as well. But in 2019, we saw, again, a spike in those cases. We had 68 cases of congenital syphilis in 2019. And that's a little typo. We had 43 cases in 2018, you'll note from the previous graph. But we had at least one case reported from every public health region. And 68% of those cases were concentrated in 4 regions, our New Orleans, Baton Rouge, Shreveport, and Monroe regions, which are our major metropolitan cities within the state. About 74% of those cases were mothers of African-American descent, as well as 25% were white. And that is a small shift in what we had been seeing from previous years. We did see about 86% of women were African-American in previous years, but then now we see that that's beginning to disperse a little bit more among white women as well. And about 41% of mothers were under the age of 25. So we're talking about a very young population that we need to address. Next slide. And when we look at the geographic distribution of the congenital syphilis cases, you'll again see this pie chart shows you how those cases were distributed amongst those 9 Office of Public Health regions I showed you on the map. And you see again where a large block of those cases were major areas of the state: New Orleans, Shreveport, Monroe, Baton Rouge. Next slide. And something to pay attention as well in Louisiana, we've heard many times that prenatal care is an issue in some states with regards to preventing congenital syphilis, but we're very pleased in our state to say that we do have access to prenatal care amongst women who give birth to cases that are considered congenital syphilis. From what we see in our case reviews, these women do access prenatal care, but there continues to be an issue with late-term infection and reinfection, not getting timely treatment before delivery. So prenatal care we see is very good amongst these cases. And also to note, in 2016, we became a Medicaid expansion state when our governor, John Bel Edwards, took office. That was his first executive order to expand Medicaid. So that in itself also helped us with increasing access to prenatal care. And you note that, next slide, you also note that almost 78% of those congenital syphilis births were covered by government or public insurance, which is primarily Medicaid. Next slide. And when we start to talk about innovations in our congenital syphilis prevention, we really start in 2016 when we developed our regional CS case review boards. And those case review boards were comprised of members of the team from both central office, where we had myself, the deputy director, as well as our perinatal surveillance manager, our CD public health advisor, a field ops manager, and then joining with the regional teams, our regional medical directors, regional nurse managers, and our regional DIS, to really take a deep dive look at these individual CS cases. And what we found from those reviews is that there will continue to be an issue with access to timely treatment for women who were diagnosed with syphilis during pregnancy. There were recurrent late-term infections or reinfections where the partner did not get treated. And there was inadequate treatment during pregnancy, where we saw that providers perhaps were not treating based on syphilis staging, which was at the time, definitely the recommendation from CDC. So in some cases, we have patients who were diagnosed as late latent who only received one dose of Bacillin, which at the time, of course, was inadequate treatment. Next slide. So when we talk about combating congenital syphilis in our state, we know that we as a health department cannot do this alone. So we had to create partnerships to really address this problem. Next slide. And we did already have a data sharing agreement with our Medicaid team in place, but we just thought this was a great time to leverage that relationship and translate some of that data we were seeing on the Medicaid side into helping us do some targeted provider outreach around congenital syphilis. Next slide. And we created what was called at the time with our Assistant Secretary of Public Health, Louisiana Office of Public Health Big Bet. And these were priorities for our agency to address that we felt could impact the general population. And so we created as our objective to reduce the number of congenital syphilis cases by increasing access to appropriate syphilis treatment and utilizing Medicaid syphilis testing of pregnant women to improve those provider services. So that's a mouthful, but basically saying we were going to take the data that we had around syphilis testing, first and third trimester testing, and use that to help inform providers about their testing rates and also give them support in how to improve those rates. And in this particular case, we focused on third trimester data. Next slide. And if we take a look at it, why we chose to focus on third trimester data, when we looked at our Medicaid data, because like I mentioned previously, the majority of these congenital syphilis births were to moms whose deliveries were covered by Medicaid, we saw that we did pretty well with first trimester testing, but third trimester testing seemed to be lacking. So when we took a look at our early third trimester testing, and that is defined as testing recommended between 28 and 32 weeks of gestation, we saw that 27 of those 68 cases that we had, there was no early third trimester test done. 41 of those did have an early third trimester test. Next slide. And when we look at whether there was any third trimester testing that took place, in 23 of those cases, there was no third trimester test done. And 45 of them did have a third trimester test at some point during the third trimester, meaning that it may not have happened early in the third trimester, but at some point during that last trimester of pregnancy, they did receive it. Okay, so next slide. So that was important because, like I said, with our congenital syphilis case review boards, we found that there was late term infection or reinfection that was taking place. But our idea is that if the early trimester test done, there was more time to get that patient adequately treated prior to delivery. And if we could inform the providers to possibly flag or make note of those patients who may have had a previous syphilis test, previous positive test, and were treated, that would flag them to try to get them in earlier. But sometimes there are barriers to that, and we recognize that with regards to scheduling and patient transportation and things like that. So that also led to some of the work that we did in the interventions we'll discuss later in the presentation. So what did we exactly do with that information? We had a nurse educator that was hired through our enhanced congenital syphilis prevention activities, who followed up with providers, specifically in New Orleans and Shreveport, which were two of our higher morbidity regions. And they focused in on providers who had low syphilis screening rates based on the data that we had from Medicaid, because we were able to drill that down to provider level data. And so that nurse educator was able to have some one-on-one training sessions with those providers, as well as offer them not just the training and education in person, but also we had some written materials that we developed, and also some training tools like little reminder cards that we had on a little ring that we developed that the providers really liked and they could share with their nursing staff. And also we developed patient and provider education materials that were able to be shared to remind both the provider and the patient that about the importance of screening and appropriate timely testing. And we do plan to look at our calendar year 2019 data from Medicaid to see how those rates have done over the 2019 calendar year. Next slide. We also developed a perinatal case management process. And our perinatal case managers were tasked with connecting pregnant women and women of childbearing age who were newly diagnosed with syphilis into medical care and community-based services. And we didn't just focus primarily on pregnant women, because we thought these perinatal case managers had the capacity to do more than just that limited number. Because we also wanted to focus on women, as I said, because we offer reproductive health services as well. If they were diagnosed with syphilis within childbearing age, we wanted them to be able to be syphilis free, and also assist them with, managing their contraceptive or reproductive health as well. So preventing them from getting pregnant before they are adequately treated was important as well. So we saw that was a good group for the case managers to engage as a part of their work. They were able to offer services that supported treatment adherence, following up with the women to make sure they were adequately treated, helping to engage their partners to get them treated, to avoid reinfection, and offering education to both. And they were also able to help with navigating services, such as, like I said, in 2016, when we expanded Medicaid, they were able to offer these ladies assistance with navigating services, because as we all know, sometimes that can be kind of tricky as well. And having some support in doing that promoted not just reducing the risk of syphilis, but overall health and well-being as well. Next slide. And so our perinatal case managers did offer support with navigating transportation services, because like I said, we do have a very poor state overall, and we have many areas that are considered rural across the state of Louisiana, and there is no public transportation system. And also there aren't Uber services and things like this that we have in more metropolitan areas. So they help them navigate getting transportation services, helping to assist with housing, and even getting access to food banks from some of our rural areas. That was a challenge for some. So they were really helpful in a lot of ways, and supporting engagement in prenatal care, accessing WIC, and also our Nurse Family Partnership program, which is for first-time moms here in our state. There was more one-on-one sexual and reproductive health education that could happen with our perinatal case managers that didn't necessarily happen with our DIS, because many times, based on the caseload that our disease intervention specialists, our DIS, have, they don't have time to really do that kind of one-on-one education and more extensive education that the perinatal case managers could offer. And they also strengthened outreach efforts around PrEP and HIV prevention among women of childbearing age. And what we saw is that we weren't having a lot of engagement from women in that age group around accessing PrEP services. So they were in their work and building these relationships and having these conversations and building the rapport, they were able to offer that education as well. And of course, they strengthened our communication and relationships with our local providers, because they were able to go in and do one-on-one trainings, offer support to the nursing staff in facilitating communication between DIS as well as some of the local providers. They were able to have time to do outreach and community education, participate in community fairs, and also grand rounds education that happened with some of the providers and physician groups. So they've been really instrumental in the work that we've tried to do around our CS prevention. And our perinatal case managers primarily cover Region 2, which is Baton Rouge, and Region 7, which is Shreveport, our two major metropolitan areas, also considered high morbidity regions. Next slide. And our most recent activities include our biosil and delivery programs. And first, we started with our syphilis home observed treatment program. And as we talked about previously, we noted that transportation was an issue sometimes in our state, as well as I'm sure as many of you will recognize in your own states, there are issues with scheduling, childcare, people returning to clinic for their appointments. So we thought we could revert back to traditional old-fashioned public health nursing and actually going into the home to deliver biosil services to women and their identified sex partners. So that was our SHOT program. And then we have our SHPDirect program, which is our biosil to private providers program that we developed, hearing from our providers that there continued to be an issue with Bacillin being cost prohibitive to have on site. So if they didn't diagnose a lot of syphilis in their practice, it didn't make sense for them to buy a box of Bacillin for $1,600 if they only treat 1 or 2 people over the course of a year. So next slide. So our SHOT program was developed and piloted in regions 4, 6, and 7, which for us were Lafayette, Alexandria, and Shreveport regions. And this project was piloted with pregnant women as well as their identified sex partners. And to be eligible, there had to be no history of penicillin allergy, because as we know, Bacillin can create anaphylactic reactions if there's a penicillin allergy. And if there were women who were pregnant in the program, they could not have any complications associated with that particular pregnancy. There must have been access to a working telephone and or cell service and availability of 911 or EMS services for us to go out into the home to provide the service as well, just in case there was a reaction that required EMS services. And this was a home visit that was conducted in partnership with our OPH nurses, accompanied by a DIS or a CS case manager on those visits. Next slide. And with the SHPDirect program, it was again a way for us to provide Bacillin to private providers who were not 340B eligible, mind you. And it was a program that was developed to allow our DIS to deliver Bacillin to the private OBGYN providers or a community health center, because we did partner with some FQHCs on this. And to ensure that there was Bacillin available for primarily pregnant women initially, and then we expanded it beyond that because of COVID response. But it was to allow us to ensure there was Bacillin available for timely treatment for patients diagnosed with syphilis. Next slide. And we implemented SHPDirect in 2019. We again piloted in those same regions that were familiar with our SHOT program, regions 4, 6, and 7, and we limited it to OB providers initially just to try to manage costs. But because of COVID response, we were allowed to expand that statewide, and there was an increased demand because of COVID for this program. And since its inception, we've delivered 304 syringes of Bacillin through the program, with over 70 patients treated as a result of SHPDirect. And again, this program was offered to providers or facilities that did not have Bacillin on site, or if they were not 340B eligible. And there were also Medicaid providers who, the Medicaid providers had to be responsible for administering the medication and doing so without passing on costs to the patient. That was part of our agreement. Next slide. So that concludes my formal presentation. I definitely acknowledge Jessica Friedge, who is our SHP Surveillance Unit Manager, Margarita Dalton, our perinatal data manager, and our perinatal case managers who did contribute to this presentation. And that concludes my presentation. Thank you.
Thank you, Chaquetta. I will now hand it over to Amanda and Jessica to go ahead and share their presentation and get started with all their information.
Thank you so much, Megan, and thank you so much, Chaquetta, for such a great presentation. I should probably turn on my video. So we're going to talk a little bit about innovative prevention strategies that we're trying out in Texas, and there is some overlap with Texas and Louisiana and some of the things that we're doing. So again, some background on our partner services in Texas, or what we like to call public health follow-up in the Lone Star State. We are an integrated HIV and STD partner services program. However, unlike Louisiana, we are decentralized in our partner services. So we have both regional and local health departments, as you can see in the map. We have 18 different jurisdictions which service 254 counties, and we have approximately 110 DIS, and at any given point, we're around 80–85% staffed. However, as you heard Chaquetta mention, due to COVID, we have several of our DIS, a little bit more than several, pulled for COVID reassignments. We do have central office staff that work on public health follow-up. We have 4 public health follow-up consultants, 3 project coordinators, 1 STD nurse consultant, and our STD program manager. Additionally, one thing to know about Texas's population is that in 2018, which is the year when you will see all of our data from, we did have a population of around 29 million persons. And so today we'll talk about our data, some pregnancy ascertainment tips and tricks, our congenital syphilis investigation practices, and our case review boards, and how we're conducting provider education. And with that, I'm going to turn it over to Jessica.
Good morning, everyone. So what does congenital syphilis look like in Texas? In 2018, Texas reported 367 congenital syphilis cases and had a rate of 92.2 cases per 100,000 births. Nationally, 41 out of 50 states reported at least 1 case of congenital syphilis, and the majority of the cases came from the South and the West. Texas ranked first in both case number and case rate, with 50 Texas counties reporting at least 1 case. Now, here's the average case rate of early syphilis among women of childbearing age in Texas and the United States. And as you can see, Texas has consistently reported higher than the national average for early syphilis among women of childbearing age. So looking at case numbers in Texas of early syphilis among women of childbearing age, as well as congenital syphilis cases, you could see that the increase of syphilis in women are associated with the increase of congenital syphilis cases. In 2018, not only did Texas report the highest number of congenital syphilis cases since 1993, but the Texas congenital syphilis rate was triple the national average. Now, this map of Texas shows the proportion of congenital syphilis and syphilis cases among women of childbearing age in 2018. Our high morbidity areas include Houston, Dallas, San Antonio, and Public Health Region 11. In 2018, Houston had the highest number of congenital syphilis cases at 104, as well as the highest number of syphilis cases among women of childbearing age at 542. And among our reporting jurisdictions, San Antonio had the highest congenital syphilis case rate at 217 per 100,000 births, which made San Antonio 7 times the national rate. Now let's take a look at some demographic information for women delivering infants with congenital syphilis. At the time of delivery, nearly half of the mothers were 25 to 34 years old, and 90% of women were under the age of 35. Nationally, syphilis is disproportionately affects women of color, and Texas mirrors that trend. Approximately 9 out of 10 infants with congenital syphilis were born to Hispanic or Black or African American Texan women. As previously stated, the South and the West report the majority of cases in the United States. In the South, the most common reason for congenital syphilis cases is inadequate treatment. As you can see, Texas shows a similar pattern, with 72% of women delivering infants with congenital syphilis. They had either inadequate syphilis treatment or no treatment at all. And in the West, the most common reason for congenital syphilis cases is no prenatal care or lack of syphilis testing. This is another area Texas mirrors the national trend. Despite 76% of women engaging in prenatal care, 25% did not enter prenatal care until the second trimester, and 17% had no prenatal care. Unfortunately, at this time, we do not have data on adequate prenatal care, such as number of prenatal care visits throughout pregnancy. And while Texas is technically in the South for the Department of STD prevention, we do border the West, and we can see the similar trends and reasons for our congenital syphilis cases. I'm going to go ahead and pass it back over to Amanda to discuss some state programmatic interventions.
Amanda, we actually can't hear you.
Thank you for catching that.
Yes.
I was going straight ahead. So even if you don't have 367 cases, you might feel a little overwhelmed when you're initially developing your congenital syphilis initiative. So be sure to start with reviewing your local morbidity. As you heard Jessica mention, many of our cases are localized in our high population centers. And we found that pretty easily. And then we had to focus our initial response efforts there. We also noticed that we needed to improve our field staff's understanding of the CSTE congenital syphilis case definition. And we did that by creating easy to use field tools. We also required reporting on all syphilis exposed infants since we needed to improve our field staff's understanding. And we also required multi-layered approvals and reviews. So our first step in capacity building was to provide some overall guidance, answer field questions, and discuss specific cases with our field staff. And this included monthly calls that began after our first initial case increase in 2017 with our 4 highest morbidity reporters, as Jessica mentioned, Houston, San Antonio, Dallas, and Public Health Region 11. This expanded following our 2018 data closeout to include jurisdictions reporting 10 or more cases. Unfortunately, this activity was scaled back in 2020 due to COVID responses, and we have continued contact with all programs via email and continued our monthly call with our highest morbidity reporters. It is super important that programs feel invested in these capacity building activities, and so they should also feel empowered to reach out to additional staff that may be interested. We did publish our congenital syphilis program operating procedures and standards this year. They are available on our website, and they really help guide our disease intervention specialists, congenital syphilis specialists, frontline supervisors, and additional field staff on how to interact with persons who are pregnant, persons of childbearing capacity, and how to complete congenital syphilis investigations. So we did also create a congenital syphilis case classification flowchart, and I'm going to go ahead and see if I can pull it up for y'all. And the nice thing about this flowchart is that it's a clickable flowchart to follow the CSTE case definition. When was mom diagnosed with syphilis? Did she complete her treatment appropriate for her surveillance stage? We say no. Did mom deliver a live birth? Yes. And this is a probable case. And down the right side of the chart, it shows the infant criteria, and that really helped us determine, you know, if this is a case or not. And it really helped our field staff cement their knowledge of congenital syphilis case classification. So we next needed to move towards pregnancy ascertainment and training our DIS to feel comfortable talking to clients about pregnancy status. So we had them ask a few questions like, when was your last normal menstrual period, to offer pregnancy tests. Initially, we were, when we were going to field, we did have pregnancy tests in our field blood kits. What medications are you taking? Not only does this help us find out if the client was on contraception, but also if they're taking things like PrEP or they may have taken incidental antibiotics. How many children do you have? We can always follow up on the ages of children for possible previous missed congenital syphilis cases, but also partner clustering around the father of the children and maybe elicit a partner. And additionally, when was your last pregnancy? And we found this to be a really important question. It is required for us in our MAVEN-based surveillance system, but we were finding cases of congenital syphilis because we had women diagnosed within 90 days of delivery. The next step for us was referrals and breaking down the one key question. So asking clients, what are your future plans regarding pregnancy? When would you like to become pregnant? And what referrals would you like to prevent pregnancy until then? And obviously all of these questions are variable by response, but it helped our staff know when to refer to OB, when to refer to contraception, or even when to refer to longer contraception, like long-acting reversible contraception or LARC, when a client said, I don't want to become pregnant for a long time. So we started to provide some resources. So this was requested by our field staff so they could provide it with our clients, and it became available online this year. And it includes links to a program called Healthy Texas Women, which provides birth control and women's health services at low or no cost across the state through various different clinics. And the nice thing about this is it also includes referrals to both pregnancy Medicaid, perinate CHIP, and Medicaid eligibility. So this was something that, clients have, as you heard Chaquetta say, clients may have difficulty finding that on their own. And it also is a really easy to use format for clients, and providers can just put this on a bulletin board as well. So the next step for us in terms of continuing our capacity building was to use our labs and our available resources. So our laboratory data does have the ability to import with pregnancy status. So you can see Jasmine of Agrabah from the movie Aladdin has the encounter for pregnancy. This is a prenatal lab. It's Medicaid initiation and initiation of prenatal care. And when we go to use this database feature, and we do have MAVEN, so this may not be available for everyone, is that because we know it's a prenatal care lab, this is a new STD and pregnancy field record, so it's a high priority field record for our DIS, and they know they have to work this a little bit faster. So again, they enter the pregnancy status into the field record, and they enter it again into the clinical question package. And once they do that, it automatically lets them know that they need to complete a congenital syphilis investigation. Once they enter the gestational age into the clinical question package, it gives them an approximate due date. So they know, hey, if I don't have delivery labs on Jasmine in January, I need to call the provider and figure out where she delivered, or call Jasmine and figure out what's going on with her. So our maternal treatment adequacy is something else we were really working on. As you heard Jessica mention, we had a large proportion of our 2018 cases that were classified as congenital syphilis cases due to no treatment or inadequate treatment. So where do you even begin when you have 72% of cases that are due to inadequate or untreated syphilis? We began by record searching and having our staff look at historical documentation of inadequate treatment for syphilis case classification when new syphilis labs would come in, so even if they're serofast. And looking to review the most recent case classification to see if there was a need for additional treatment. And this sometimes required them to look and see if a case classification needed to be modified. I might have been diagnosed with early syphilis in 2017, but maybe that case should have been closed as syphilis of late or unknown duration, and I needed 3 shots instead of just 1. So the other thing we had to have them do is review historical titers. Any missed investigations with sustained 2 dilution titer rises with the absence of treatment. Prior to 2019, Texas was using STD-MIS, and we required manual review of all labs. So there were some investigations that may have been missed because we're all human. So what next? Why are we even doing this? This is a labor-intensive activity, and how do we prevent future congenital syphilis cases when mom was historically inadequately treated? This seems like a laborious initiative. So in MAVEN, we have the ability to have a treatment restart field record, and so we began to follow up on these women to reduce the number of persons who deliver infants classified as congenital syphilis cases due to historical inadequate treatment. And this is a required activity for all of our programs. When they receive positive syphilis lab results, even serofast labs, and report a pregnancy from a provider, a DIS, or a laboratory. And this includes positive labs from delivery. And this is because this is new locating information, and we're still evaluating the efficacy, how many field records result in reduced, not how many field records result in cases averted, but even one case averted is a success. One of the first things that we did when we're talking about investigations, I said I would speak to investigations, was that we updated our STD 126 form, which hadn't been updated since 2013. So we did need to update it to reflect the 2015 and 2018 case definitions and the required reporting fields. So we included our new flow chart at the bottom for easier case classification determination for our field staff. And sites in Texas are required to investigate and report on all infants born to women with a history of syphilis. You heard me say that earlier. So once sites get really comfortable and achieve a high rate of accuracy and completeness in reporting investigations in the STD 126 and in MAVEN, then they are offered this short form, this STD 126A, or abbreviated STD 126. And we worked with CDC when we were the recipient of a supplemental congenital syphilis award in 2017 to identify some additional fields for reporting that can often contribute to congenital syphilis cases or be barriers to care, such as insurance status or housing instability or incarceration history, prior CPS involvement, substance use, or other medical conditions. Reviewing investigations, I can't stress this enough. So congenital syphilis investigators at the local level complete the STD 126 and the question package in MAVEN. A supervisor locally reviews it, and then central office reviews it. So Jessica or I spend a lot of time reviewing these. And then weird cases go to the central office review board. I strongly suggest including a clinical, someone with a clinical background if you have this option. So you heard Chaquetta say that she looks at cases, and we include our STD nurse consultant, Pam Matthew, on ours. And then central office may need to reopen investigations for additional follow-up on mom or baby. So CS case classification may need to be modified. Historical maternal morbidity may change, and infants may require additional follow-up if they were not appropriately evaluated or treated at the time of delivery. We also found that we really needed to work on our cross-jurisdictional reporting. So we have 18 different jurisdictions, we are decentralized, and many of our jurisdictions neighbor each other or are located within one another. We also border 4 states in another country. So we had to encourage our local jurisdictions to really talk and work together. And you may know that encouraging people is not always enough. So we had to establish a strong out-of-jurisdiction policy consistent with timely reporting and CSPE guidance. We also established contact persons in neighboring states, as we have had to report cases in conjunction with New Mexico, Arkansas, and Louisiana. We are also working with the Texas Department of State Health Services Office of Border Health to improve reporting and outcomes with Mexico. So training. We were able to hold a congenital syphilis symposium for field staff in 2019, where we went over the CFTE case definition, we went over clinical scenarios, pregnancy ascertainment, provider education, field practices, and medical chart abstractions. And we provided a large amount of just training and reference materials, and we do have all of this available. And again, this was in 2019, so don't let that very large group of individuals together all in one space without masks scare you. So we do have case review boards in Texas. Texas does use the fetal infant morbidity review tools for enhanced congenital syphilis case reviews, and we use that to look at missed opportunities for disease interventions and barriers to care. We have one in Houston, San Antonio, and Dallas, And those 3 area femurs represent 75% of all of our cases. Our Houston femur also reviews perinatal HIV, and I will give a short shameless plug here, is all of these meetings are currently virtual. So if you are interested in attending any of them, please shoot us an email following this presentation. How would you set up a case review board if you're interested in it, or what are we doing? So we identify ours in the way that we would like to. We'd love to review all of our congenital syphilis cases in an enhanced review methodology with our femur, but we have too many. When you have 367 cases, that's just not possible. So we have to prioritize our cases. So we try to review all of our syphilitic stillbirths and perinatal deaths, our confirmed cases, and then our really symptomatic cases and all other probable cases. Another thing that we really take into account is other social determinants of health and barriers to care, so that we're looking at cases that really drive the conversation in our case reviews. We also try to look at cases timely, so local jurisdictions work with central office to identify and review cases within 90 to 120 days of the infant's date of birth. So also in our version of Maven, we do have an option for jurisdictions to mark a case for femur for central office to take a look at. So we have some components of our femur. We have these enhanced medical chart abstractions that look at several different points of care for both mom and baby. We have a maternal interview, and we adopted the syphilis maternal interview from the Fetal Infant Mortality Review Board. We initially used that format, but we did modify it to meet our community needs and create more open-ended questions, as well as adjust the flow to be more conversational. So a really long interview, it's about 50 pages. And we have a case review process, as well as we identify community action items together. So when you're doing this internally, and you heard Chaquetta talk about this, you should involve your state health department staff, and these people seem pretty obvious. Your local jurisdictional staff, again, these are the people who worked on the case. So I'm not going to go over this in too much detail. But if you get ready to expand this to include external stakeholders, use that initial group of persons who worked on those cases to build up what we call a core team. And recruit external partners locally. So I don't know what's going on in Houston because I don't live in Houston. And so you want the Houston group to recruit who they think should be at the meeting to bring those external stakeholders to the table. Plan those meetings together, right? So decide your meeting frequency and location. The location's online right now, but make sure it's PHI compliant. Decide how many cases you want to review at every meeting, and establish timeframes for each cycle, as well as how are you going to share your case summaries? Are you going to host them? Or are you going to send them somehow totally de-identified via email? And be accountable to one another. So meet your deadlines and start small, right? That's the one thing I can say to everybody is that most of our groups, we started meeting internally, reviewing one case at a time, once a month, and giving each other a lot of feedback and collaboration to figure out what really worked best for us before bringing in external stakeholders. So again, expanding, we have these core team roles. They're super intermingled, and you're going to have a lot of overlap here. And then you have your external case review board members. So you have healthcare practitioners, such as clinicians, nurses, social workers, and counselors, representatives from local systems of care, hospitals, CBOs, FQHCs, doctors' offices, and other systems access are available to persons who are pregnant or may have syphilis. So criminal justice systems, CPS, WIC, Medicaid, MCH, and I could go on all day. STD program staff, and of course, other health department staff as appropriate. So what are some of our case review board and community action item outcomes? So we've noticed across the state some trends in systemic issues or barriers to care. So mental health and housing instability, substance use and abuse disorder, transportation. We don't have great public transportation in Texas either. Involvement with corrections, domestic and intimate partner violence, prior involvement with CPS, implicit bias of providers, or providers not following the testing laws. So we always have, as a community action outcome in every meeting, we end up doing ongoing provider education. We were able in Houston, the Houston FEMUR successfully went to the legislature last session in Texas and was able to successfully pass a pilot program to allow for transportation of other minor children under Medicaid to improve prenatal health care outcomes. And the San Antonio FEMUR was able to get pregnancy crisis centers to adopt routine syphilis testing when they noticed a trend where women would go to pregnancy crisis centers, find out they were pregnant, but there was delayed entry into prenatal care. So you heard me talk about provider education. So if you're going to do provider education, what should you know? You should encourage providers to report, especially for pregnant persons. And so explain that as the local health authority, additional syphilis lab results and treatment history is available. And our golden ticket in Texas, since we have so many people moving here, is letting them know that, hey, we can give out-of-state history. So if someone comes in and says, hey, yeah, I got treated in Louisiana, we say, hey, we can get that for you from Louisiana. And that's been really helpful for them to know and makes them more encouraged to call us. Be knowledgeable about your national, state, and local trends. A lot of providers don't know that congenital syphilis has made a comeback. And know your local testing laws. So in Texas, it is required to test at the first prenatal visit, third trimester, and again at delivery. So just know what your state requirements are. And know the CDC treatment recommendations for syphilis, pregnant persons with syphilis, and for infants. So infant testing and treatment is confusing. So and we developed our own flow chart for providers, since many of them look at the Pediatric Red Book and the CDC treatment guidelines, and they're both, they look a little different, but they're the same. So we have this flow chart so providers can identify the clinical scenario for the infant and then determine what the evaluation and treatment they should follow. Excuse me. And we are continuing our provider education by hosting a congenital syphilis provider symposium right now. We have another one coming up in a few weeks. And I just want to thank you at HCET for allowing us to present today.
Thank you to all three of you for all of the great information. We are running close on time here, but I do just want to throw out probably just two quick questions, and we'll try to follow up by email. Please reach out with any questions that we don't get to today. But for Chaquetta specifically, Louisiana has a law that requires third trimester syphilis screening. And there was a question about whether this law was used to improve rates among providers who were not previously doing third trimester screenings.
Okay, thanks for that question. Yeah, in 2014, actually, we expounded on our previous HIV and syphilis testing law, and we required that there was opt-out testing that was offered for women at first trimester, third trimester, and at delivery if their testing status was not documented on the chart. So it was done actually when we did see the increasing case numbers, CS case numbers in the state. So it wasn't just done at that time to increase the testing, but we also wanted to make sure that you know, it was on the books and in place and in keeping with what CDC recommendations was additional third trimester testing for high morbidity states.
Thank you. And then for Amanda and Jessica, there was a question of, can DIS directly access STD records from other Texas regions without having to request a record?
Yes. So we do have a centralized database. So DIS are able to see all records and all history going back, I think, to like 1999. And then at central office, we have records going back to the 50s.
Awesome, thanks for that. And there were so many great questions, and we did write them down and document them. So we'll try to work with our presenters today to get some of those answered and get back to you guys with some of your questions. But in the interest of time, we do just need to wrap things up. So I want to again give a thank you to Chaquetta, Amanda, and Jessica for all of the great information today. And we hope you guys have a great rest of your day and join us for another training again soon. So thank you, everyone.
Thank you.
Thank you.